want to ask you something that will sound strange. When was the last time you thought about your ears? Not in terms of hearing, not in terms of pain or infection, just your ears, the outer structure, the small canal, the ringing that comes and goes. The way sounds seem slightly different than they used to. Most people cannot remember, because the ears are the part of the body that almost nobody includes in a conversation about metabolic health. They are not something we are taught to examine. They are not something we think about between ear infections and hearing tests. And that is precisely why I want to talk about them today. Because after 2 decades in medicine, the pattern I keep seeing, in cases, in research, in patients who came to me with metabolic dysfunction that had been building quietly for years, is that the ears were trying to say something long before anything else did. Not loudly, not dramatically. In the way that early signals always work. Quietly, gradually, in a language that most people do not know how to read because nobody ever taught them. Today I want to teach you that language. There are 9 specific changes in and around the ears. Observable, specific, biologically explainable changes that have documented associations with insulin resistance, elevated blood sugar, and early diabetic vascular and neuropathic damage. Some of them you will recognize immediately. Some will surprise you. And one of them I will tell you now, because telling you now is the reason you will stay to the end, is so counterintuitive, so completely outside what anyone has ever told you to watch for, that I have watched it produce genuine shock in people who have been managing a diabetes diagnosis for years without ever hearing it mentioned. This is not a diagnostic tool. None of these signs replaces a blood test. What they are is a framework, a way of noticing what your body has already been showing you in a location you were never taught to look. Keep reading. And if you can, reach up and touch your ears right now, because some of what I am about to describe you may be able to feel. Let me start where I always start, with the biology. Because a list of signs without a mechanism is just a list of things to worry about. A list of signs with a mechanism is a map, and maps give you direction. The ears sit at an unusual intersection of biological systems. The outer ear, the auricle, the canal, and the eardrum receives blood supply from branches of the external carotid artery system, including the posterior auricular and superficial temporal arteries. These are medium to small caliber vessels. They are not the smallest in the body, but their terminal branches, the ones that supply the delicate skin of the ear canal, the eardrum, and the highly specialized microstructures of the inner ear, are among the most fine caliber vessels in the human circulatory system. The inner ear is where the most critical vascular supply exists. The cochlea, the spiral structure responsible for converting sound vibrations into neural signals, is supplied by a single vessel called the labyrinthine artery, also called the internal auditory artery. It is an end artery. There are no collateral blood supplies that can compensate if it is compromised. If flow in the labyrinthine artery is reduced, there is no backup system. The cochlear hair cells, the most metabolically demanding sensory cells in the body, receive less oxygen, less glucose, less of everything they need to function. The auditory nerve, the 8th cranial nerve, carries those neural signals from the cochlea to the brain. Its peripheral fibers are among the most exquisitely sensitive nerve structures in the body to the metabolic environment around them. And the skin of the outer ear and ear canal is some of the thinnest, most delicate integumentary tissue in the human body. It sits over structures with minimal subcutaneous cushioning and is directly responsive to the vascular and inflammatory changes that metabolic dysfunction produces. This is why the ears reveal so much in early metabolic dysfunction. The vascular supply is fine caliber and unforgiving. The neural structures are metabolically demanding and sensitive. The skin is thin and directly responsive. Every system that elevated blood sugar and insulin resistance damages first. Microvasculature, peripheral nerves, skin structure, converges in a small, examinable space that most people and most medical appointments never look at carefully. Now, the 9 signs. The first sign. Gradual, progressive hearing loss, particularly in the high-frequency range, that cannot be fully explained by age or noise exposure history. I want to approach this one carefully because the overlap between age-related hearing loss and metabolic hearing loss is real. And I do not want to create alarm in every person over 50 who has noticed that high-pitched sounds seem slightly less sharp than they used to be. The distinction I am drawing is in the pattern and the rate. Age-related hearing loss, presbycusis, follows a characteristic audiometric pattern. It typically begins in the highest frequencies, progresses slowly and symmetrically, and correlates reasonably with overall biological age and cumulative noise exposure history. Diabetic and insulin-resistant hearing loss follows a similar frequency pattern, beginning in the high frequencies, but with a rate of progression that is measurably faster than age and noise exposure alone would predict. Multiple large-scale epidemiological studies, including analyses from the National Health and Nutrition Examination Survey, have found that people with diabetes have approximately twice the prevalence of hearing loss compared to age-matched controls without diabetes. Twice. Not a marginal difference. The mechanism is microvascular. The cochlear hair cells, particularly those in the basal turn of the cochlea, which are responsible for high-frequency hearing, are the most metabolically vulnerable cells in the inner ear. They require a continuous, precisely regulated blood supply through the labyrinthine artery and its terminal branches. When microvascular disease reduces that supply, through the same endothelial damage, basement membrane thickening, and reduced vasodilatory capacity that elevated blood sugar produces in every small vessel bed, the cochlear hair cells are among the earliest casualties. The cells at the basal turn die first because they are at the end of the vascular supply chain and because they are the most metabolically demanding. High-frequency hearing goes first. The loss is often not noticed until it is significant because the brain compensates and because high-frequency loss is most apparent in specific acoustic environments, distinguishing consonants in conversation, hearing speech clearly in background noise, rather than in overall volume perception. If your high-frequency hearing has been declining at a rate that feels faster than gradual aging should explain, if you have been saying "what" more than you used to, if speech in noisy environments has become noticeably harder to follow, that observation belongs in a metabolic health conversation alongside a hearing evaluation. The second sign, tinnitus, a ringing, buzzing, hissing, or pulsing sound in one or both ears that has no obvious acoustic cause. Tinnitus is one of the most common symptoms in adults over 50, and most of it has causes that are unrelated to blood sugar. I want to be clear about that. Noise exposure, medication side effects, earwax impaction, and a dozen other causes are responsible for the vast majority of tinnitus in the general population. The tinnitus I am describing has a specific character. It tends to be bilateral, in both ears. It tends to be of the higher-pitched variety, and it has a temporal pattern. It is often worse when blood sugar is poorly controlled, higher in the hours after a high-carbohydrate meal, for example, and somewhat improved when metabolic conditions stabilize. The mechanism involves two converging processes. The first is vascular. Tinnitus can be generated by turbulent or reduced blood flow in the cochlear microvasculature. When the small vessels supplying the cochlea are narrowed or their flow is made turbulent by the vascular changes of insulin resistance and elevated blood sugar, thickened basement membranes, reduced endothelial nitric oxide production, increased blood viscosity. The cochlear hair cells begin generating spurious signals that the brain interprets as sound even though no external sound exists. The second is neuropathic. The auditory nerve fibers, like all peripheral nerve fibers in a metabolically compromised environment, can become hyperexcitable. Spontaneous firing, the same process that produces burning sensations in the hands and feet of people with diabetic peripheral neuropathy, in the auditory nerve produces the perception of sound without an external source. There is also a third element specific to blood sugar fluctuation. The cochlea is exquisitely sensitive to glucose availability. Cochlear hair cells cannot store glycogen. They are entirely dependent on continuous glucose delivery from the blood. When blood sugar fluctuates sharply, the postprandial spike followed by reactive hypoglycemia that characterizes insulin resistance, the cochlear cells experience brief episodes of substrate insufficiency. Those episodes generate abnormal electrical activity that is perceived as tinnitus. Tinnitus that fluctuates with meals, worsens after carbohydrate-heavy eating, or improves meaningfully when dietary patterns are adjusted, is not coincidental. It is the cochlea reporting on the metabolic environment in real time. The third sign, a diagonal crease in the earlobe, specifically a crease that runs from the opening of the ear canal diagonally downward and backward across the earlobe. This is the one I mentioned at the beginning, the one that consistently produces the strongest reaction. And I want to explain it in full because it is the most visible, most immediately examinable sign on this entire list, and the least known. The earlobe diagonal crease, sometimes called Frank's sign, after Dr. Sanders Frank, who described it in 1973, is a diagonal line that runs across the earlobe at roughly a 45-degree angle from the tragus toward the lower outer edge of the earlobe. It appears as a folded or creased line in the skin of the lobe, sometimes subtle, sometimes pronounced enough to be visible from several feet away. Its association with cardiovascular disease and insulin resistance was documented as early as the mid-1970s and has been replicated in multiple independent studies across different populations since. The association is specifically with coronary artery disease, peripheral arterial disease, and insulin resistance, conditions that share the common pathophysiology of systemic atherosclerosis and metabolic dysfunction. The mechanism is vascular. The earlobe is supplied by tiny capillary loops with no collateral circulation. When systemic small vessel disease develops, the progressive endothelial damage and reduced microvascular perfusion that elevated insulin and blood sugar produce over years, the earlobe capillaries are among the earliest to show compromise. The connective tissue of the lobe loses its normal structural support as microvascular supply diminishes. The skin loses turgor and begins to fold, producing the visible crease that Frank described. Look at your earlobes right now. Look at the lower portion of each lobe. Is there a diagonal crease, a fold running from near the canal opening diagonally downward, that was not there 10 or 15 years ago? This single sign in isolation is not diagnostic of anything. In combination with other signs on this list, and in the context of other metabolic risk factors, it is a visible marker of systemic vascular health that has been sitting in plain sight, on a part of your body you see every day that nobody ever told you to look at. Now you know what to look for. And if this is the kind of conversation, specific mechanisms, visible signs, information that translates directly into an action you can take, hit subscribe right now. This is exactly what this channel is here for, every single week. Information that belongs in the medical conversation and consistently doesn't make it there. Subscribe. Turn on notifications. Let's keep going. The fourth sign, recurrent outer ear infections, otitis externa, that are disproportionate to what your history of ear problems would predict. Most people who have experienced ear infections think of them as straightforward episodes with a clear cause. Swimmer's ear, a foreign object, excessive ear cleaning, and in most cases, that explanation is accurate. What makes this sign worth attention is not a single episode. It is a pattern. Recurrent, treatment-resistant, or unusually severe outer ear infections in an adult over 50 who did not previously have frequent ear problems. The mechanism is twofold. The first component is immunological. Elevated blood sugar impairs the function of neutrophils, the white blood cells that are the body's primary defense against bacterial and fungal pathogens in skin infections. Neutrophil chemotaxis, the ability of these cells to migrate to the site of infection, is reduced in a hyperglycemic environment. Their phagocytic activity, their ability to engulf and destroy pathogens once they arrive, is also impaired. The result is an infection that is harder to contain, slower to resolve, and more likely to recur. The second component is the skin environment itself. The skin of the ear canal maintains a slightly acidic pH through the secretion of cerumen, earwax, which serves as a chemical barrier against pathogen colonization. In people with insulin resistance and elevated blood sugar, the composition of cerumen changes. Its antibacterial properties are reduced. The glucose content of the tissue fluid in the canal skin increases, providing a richer nutrient environment for bacterial and fungal growth. Candida albicans, in particular, thrives in glucose-rich environments. Fungal otitis externa, automycosis, has a significantly elevated prevalence in people with diabetes and poorly controlled blood sugar. Ear infections that recur, that respond slowly to standard treatment, or that are caused by organisms, particularly Aspergillus or Candida, that are more commonly associated with fungal infection than bacterial, are a pattern worth connecting to metabolic health evaluation. The fifth sign: changes in the texture or appearance of the skin just inside the entrance of the ear canal, specifically skin that appears dry, flaky, or slightly thickened compared to what you remember or compared to other areas of facial skin. This sign requires a mirror and a moment of attention, and most people have never directed either at the skin of the ear canal entrance. But it is worth the 30 seconds. The mechanism involves the same autonomic nerve damage we discussed in the context of the hands. The eccrine glands that maintain skin surface hydration are regulated by small autonomic nerve fibers. These fibers are among the first casualties of diabetic neuropathy. When they are damaged, glandular output is reduced. The skin they serve becomes drier than normal from the inside, not from a failure of external moisturizing, but from a failure of the internal regulation that maintains surface hydration. The skin of the ear canal entrance is some of the thinnest in the body, and is among the first locations where this autonomic-mediated dryness becomes visible. The skin may look slightly scaly, slightly flakier than the skin of the surrounding face. In more pronounced cases, it may appear reddened or irritated, not from infection, but from the dryness and the secondary inflammatory changes that poorly hydrated skin produces. This sign is so subtle in early stages that most people who have it have never noticed it, which is precisely why I am describing it specifically, so that you know what to look for. The sixth sign: vertigo or dizziness, specifically episodes of positional vertigo or a sensation of imbalance that occur without obvious neurological cause and that are new or worsening in the past several years. I want to be clear that vertigo has many causes, and most of them are unrelated to blood sugar. Benign paroxysmal positional vertigo, BPPV, is the most common cause of positional dizziness in adults over 50, and it has a mechanical explanation involving displaced calcium carbonate crystals in the inner ear that is entirely unrelated to metabolic health. The vertigo and balance dysfunction I am describing has a different profile. It tends to be less episodic and position-dependent and more persistent, a baseline unsteadiness or mild lightheadedness rather than the brief, intense spinning of BPPV. And it is accompanied by other ear-related signs on this list rather than occurring in isolation. The mechanism involves the vestibular portion of the inner ear, the structures responsible for balance, which share the same precarious single-vessel blood supply as the cochlea. The semicircular canals and the otolith organs, which detect rotational and linear acceleration, depend on the same labyrinthine artery that supplies the cochlea. When microvascular compromise reduces flow in that vessel, both the auditory and vestibular functions of the inner ear are affected. Additionally, the large nerve fibers of the vestibular nerve, the balance component of the eighth cranial nerve, are affected by diabetic neuropathy through the same mechanisms that affect peripheral nerve fibers elsewhere in the body. Reduced axonal conduction velocity in vestibular nerve fibers produces subtle delays in the transmission of balance information that manifest as mild instability rather than dramatic vertigo. Mild persistent imbalance, difficulty walking on uneven surfaces, a tendency to reach for support in low-light environments, a sense of slight unsteadiness that is gradually worse than it used to be, occurring alongside other signs on this list, warrants metabolic evaluation alongside vestibular assessment. The seventh sign: an itching sensation deep in the ear canal, persistent, not associated with visible skin changes or infection, that recurs regularly without a clear explanation. This is one of the most consistently dismissed symptoms on this list, and dismissing it is completely understandable. An itch inside the ear canal feels like a minor irritation. It is easy to address temporarily with a finger or a cotton swab. It comes and goes. It does not feel medical. But the mechanism behind persistent, unexplained deep ear canal itching in the metabolic context is specific and worth understanding. Pruritus, itching, in the ear canal without visible skin pathology or infection is a neuropathic symptom. The sensory nerve fibers supplying the skin of the canal, branches of the auriculotemporal nerve, the greater auricular nerve, and notably the auricular branch of the vagus nerve, which gives the ear canal its unique connection to the vagal reflex system, can become hyperexcitable in the metabolic environment of insulin resistance and elevated blood sugar. Hyperexcitable sensory fibers generate spontaneous signals. In the skin of the ear canal, those signals are interpreted as itch rather than pain or burning because the sensory fiber population there is dominated by itch-mediating C fibers rather than pain fibers. The pattern that deserves attention is itch that is persistent across seasons, not attributable to dry winter air or specific exposures, bilateral in both canals, and occurring without the visible changes of fungal or bacterial infection. An itch that recurs in the same location, in the same character, without a mechanical explanation. In the context of other signs on this list, this symptom is the nervous system reporting on its own metabolic state through one of the most sensitive sensory surfaces in the body. The eighth sign, sensitivity to loud sounds, hyperacusis, or a reduced tolerance for sounds that previously felt normal. This sign tends to appear alongside tinnitus in people with cochlear microvascular compromise, and it has an explanation that is less intuitive than most on this list, but is directly connected to the same vascular mechanism. The cochlear hair cells in a compromised vascular environment become, in a metabolic sense, overloaded. They are receiving insufficient oxygen and glucose through their already compromised blood supply. Their normal sound transduction is operating at reduced efficiency, and paradoxically, when loud or intense sounds arrive, the damaged system responds with an exaggerated reaction, an amplified electrical output that the brain interprets as sound that is louder, more harsh, or more uncomfortable than it should be. It is the sensory equivalent of a dimly lit room in which a sudden bright light seems blinding, not because the light is objectively brighter, but because the system receiving it is depleted, increasing sensitivity to sounds that previously did not bother you, the television volume that now needs to be lowered, the restaurant environment that now feels genuinely overwhelming, the sound of a car door closing that now seems sharper and more uncomfortable than it used to, is a sign that the cochlear environment is under metabolic stress. Combined with tinnitus, with high-frequency hearing changes, and with other signs on this list, it completes a picture of inner ear compromise that has a specific metabolic context, the ninth sign. This is the last one, and I have saved it for last deliberately, not because it is the most dramatic, but because it is the most actionable. The sign that, once understood, points most directly toward what to do next. A change in the temperature of the outer ear, specifically one ear that feels consistently warmer or cooler than the other, or both ears that feel persistently cooler than the surrounding facial skin. Touch the outer surface of your ears right now. Compare them to the skin of your cheek, your forehead, your neck. Are they notably cooler? Is one noticeably different from the other? In a healthy circulation, the outer ear, supplied by terminal branches of the external carotid system, is slightly cooler than the central face, but not dramatically so. The blood supply maintains a temperature that reflects adequate perfusion. In progressive peripheral vascular compromise, the gradual narrowing and stiffening of the small arteries and arterioles that supply the extremities and the distal circulation, driven by the endothelial damage of insulin resistance and elevated blood sugar, the outer ears can become measurably cooler than normal. Persistent coolness in the ears relative to the face reflects reduced blood flow in the auricular vessels. A temperature asymmetry between the two ears, one consistently warmer than the other, may reflect uneven vascular compromise or, in some cases, asymmetric autonomic regulation of vascular tone, autonomic neuropathy, damage to the nerves that regulate blood vessel diameter, is an early and underdiagnosed manifestation of diabetic neuropathy that affects the small vessels of the face and ears before it is apparent in the larger vessels of the limbs. This sign is not alarming in isolation. Cool ears on a cold day are normal physiology, but ears that are persistently, noticeably cooler than your facial skin in a warm environment, particularly occurring alongside the other signs described today, are reporting on the vascular health of your peripheral circulation in a way that translates directly to a testable clinical question. Now let me bring all 9 signs together into the framework that makes them most useful. The 9 signs I have described today are not 9 separate problems. They are 9 windows into the same biological process, the progressive vascular, neuropathic, and metabolic changes that insulin resistance and elevated blood sugar produce in the structures of the ear. The microvasculature, the peripheral nerve fibers, the skin, and the sensory organs themselves. Progressive high-frequency hearing loss, cochlear microvascular compromise, tinnitus, vascular turbulence and neuropathic nerve firing in the auditory system, the diagonal earlobe crease, visible microvascular insufficiency in the lobe capillaries and systemic vascular marker, recurrent ear infections, immune impairment and glucose-rich tissue environment, dry flaky canal skin, autonomic neuropathy affecting eccrine gland function, vertigo and imbalance, vestibular microvascular and neuropathic compromise, deep canal itch without cause, neuropathic C-fiber hyperexcitability, sound sensitivity, cochlear metabolic stress and hair cell dysfunction, persistent ear coolness or asymmetry, peripheral vascular compromise and autonomic dysregulation. Every sign connects to the same root. Every sign, in the context of a pattern, tells the same story. The practical question is not whether you have any of these signs. In isolation, most of them have common benign explanations. The question is whether you have a pattern, 2, 3, or more of these signs occurring together, particularly if they are new or worsening, particularly in the context of other metabolic risk factors like abdominal weight gain, fatigue after meals, or a family history of type 2 diabetes. A pattern converts observation into clinical information. And clinical information, acted on early, is the difference between a conversation that happens in a doctor's office at 49 and a conversation that happens in a hospital at 63. The tests are simple: a fasting blood glucose, an HbA1c, a fasting insulin level if your doctor will order it, which gives you the earliest window into insulin resistance before glucose becomes markedly elevated. These tests take 5 minutes of a blood draw. The information they provide is among the most important metabolic information available to you at this stage of your life. Your ears have been positioned on the sides of your head, reporting on your metabolic health in a language you were never taught for years. Now you speak the language. Before I close, I want to ask you directly, and I want you to answer in the comments below. Which of these 9 signs did you recognize? Not which one surprised you the most in the abstract. Which one you noticed in yourself right now while watching this? Leave it below. Because when someone reads a comment that names the exact sign they recognized in their own body, something that was background noise becomes a signal, and signals can be acted on. If you are not yet subscribed to this channel, do it now. Right now, before this video ends and this conversation fades. Next week there will be another one exactly like this, and the one after, and the one after that. This channel exists for one reason: to give you the specific, mechanistic, honest medical information that belongs in the conversation and consistently doesn't make it there. Every week, without exception. Subscribe, turn on notifications, share this with one person in your life over 50 who has been living with tinnitus or gradual hearing loss or recurring ear problems and has never once connected any of it to their blood sugar. 15 seconds. It could change something that cannot be changed later. The doctor may give the recommendation, but your ears have been speaking all along. Take care of yourselves, stay curious, and keep asking the hard questions, every single one of them.